In this lecture, we will talk about a type of arrhythmia called paroxysmal supraventricular tachycardia. So, in the picture, I have drawn over here, I have shown you the normal conduction. This is a normal conduction. Here, can you see this is the SA node and it fires and it reaches the AV node. And from the AV node, this is the AV node, and AV node it travels through AV bundle and it travels to right and left his bundle, and from there it goes to Purkinje fiber and that depolarizes the ventricle. This is a normal. So to understand the reason for supraventricular tachycardia and how it is happening, let us look more closer what's happening in the AV node. So the AV node, this is the AV node. Okay. So the current travel through AV node through two pathway. So we have here faster pathway, this red one over here, and we have a slower pathway that carry impulses very slowly. Remember, though I am saying this is the faster path, in comparison to other part of the heart, AV node is definitely show slow conduction. All right, it's relatively faster compared to the slow. This is faster, much faster. So this is there are two pathway through which electricity passes, impulses passes through to the ventricle. Okay, usually when the impulse reach the AV node, it travels through the faster pathway as well as through the slower pathway. And what happening is the faster pathway will carry the impulses very fast and it reaches the ventricle. It gives the impulse, it gives the signals to the ventricle, and the ventricle will depolarizes. So normally the ventricular depolarization is happening because of which pathway? It is because of the faster pathway that ventricle is getting depolarized. Usually the slower pathway do not contribute to the ventricular depolarization, because by the time the slower pathway finished half of its journey, the faster pathway might have even depolarized the ventricle completely and started going up through the slower fiber. The faster pathway will carry the impulses very fast and depolarizes the ventricle, as well as it will go little up. It will reach the slow fiber and depolarizes, and the signal will go up, so that whatever the impulses this slow conduction pathway carrying, it will not be able to reach the ventricle. It will not contribute to the ventricular depolarization, because the faster pathway it's going even up towards the slower pathway. All right. So so this is what is normal and what happened. Now let me tell you how the pSVT happened. Let us assume that the SA node fires and an impulse has traveled through the faster pathway and has given the signal to the ventricle. So this faster pathway is now under refractory period. Okay. And the slower pathway, yes, it has blocked, the faster pathway has blocked the slower pathway, and still it is also in refractory period. But the refractory period of the slower pathway is less, so this become free for depolarization sooner. So suppose there is an atrial ectopic is happening. Okay, an atrial ectopic, and when the atrial ectopic reaches after a normal beat, as we can see here the refractory period is still higher. Here the refractory period is human with the refractory period is over, because it has got shorter refractory period. So the current will travel through which pathway? Yes, the electricity, the impulse will pass through the slower pathway. It couldn't pass through the faster pathway because it is still in under refractory period. So the current has passed, and this lower conduction even gave the impulses to the left ventricle. Not only that, it has just started traveling through the faster pathway, and now it has become a re-entry circuit. Can you see here? It started depolarization of the one area and reaches here lower part, give the depolarization to the ventricle, and it has started moving up, and it has joined the area where it started. So this area now is which charge? It is under repolarization, but this is depolarization, so it will start again depolarizing this area. So and this become a re-entry circuit, and when this re-entry circuit happen, it depolarizes the ventricle and depolarizes the atria as well, atrial depolarization. But the important thing to note here that when this keep on happening, the depolarization in the atria is happening from down to up, from down to up, which is not usual. The usual depolarization is from up to down, and ventricle is depolarizing as usual from up to down. So what we can expect in supraventricular tachycardia is an inverted p wave. Let me show you. Let me show you a diagram. Okay, so this is what exactly happening. See, there is a re-entry circuit formation, and this re-entry circuit will give current one to down towards ventricle and one towards up towards atria. So and this keeps on happening. Let me show you a video. Can you see? This is what exactly happening. One goes up, this one p wave up and down. As usual, it's the depolarization of ventricle qrs. But important thing to note here that the depolarization of the atria is happening from down to up. Ventricle, as usual, depolarization is happening from up to down. Again, look at the figure again. Look at the figure again. All right. All right. So now let me discuss about the features that we can see in supraventricular tachycardia. One of them I have already discussed, that is inverted p wave. P wave is inverted because the depolarization is from down to up, especially in inferior leads. So we get a kind of retro p waves. The p waves, it is inverted, as well as this p wave happen after qrs complex. Here, after qrs complex, not in the beginning. Where usually you get the p wave, it is before the qrs. But here you get qrs after. You get qrs after the, you get p wave after the qrs. See here, this was our circuit, re-entry circuit, and the current has started coming down, and it has given the impulse towards lower part towards ventricle, that gives qrs complex. After that, it's going up and giving impulses to the atria. So first qrs has happened, followed by p wave happen. So you get qrs, so you get p wave after qrs. Or even the p wave sometimes merges with the t wave of the same beat. So inverted p wave, especially in inferior leads pick up signals. Suppose this is the inferior lead, the okay, this one is inferior leads. If the depolarization is happening from down to up, definitely this lead will record it as negative wave as it is going. The depolarization is happening away from the lead, away from the inferior lead. All right. So we have discussed one of the feature, that is p occurs after qrs and it is inverted p wave. And another feature is the width of qrs complex. What do you think the width of qrs complex? It should be normal. qrs complex, the width should be normal, because the conduction is happening through the regular av bundle and Purkinje system. So there is no problem with the conduction. So it's not even interventricular conduction, it's the Purkinje system that is depolarizing the ventricle. So definitely it's going to be qrs. And what about the rhythm? Is it regular or irregular? Well, if you look at this picture, you can see, let me take which picture, okay, this one. Well, if you look at this picture, it's clear for you that the time taken to travel around this area, this circle, is always remain always normal. So to take one round around this circle, around this av node, it's always going to be the same. So the rhythm would be regular. So we have regular rhythm, narrow qrs complex, and p wave after qrs, and inverted p wave. These are the characteristic features of pSVT, paroxysmal supraventricular tachycardia. Let's apply this knowledge over an ECG. So if you look at here, let us first look at the rate. Two box between two RR waves. So RR interval has got two boxes. Since the rhythm is regular, we can see the distance between RR is constant. So the equation 300 will divide by number of large boxes between RR waves. So it's going to be 150. Okay, so the rate is 150. Now if you look at uh, this ECG, you can see here that, can you see this part, this area after the QRS complex, there is a dip, something like this. Can you see here? Let me show you more, a closer look of this picture. Okay, these both are same. Actually, I zoomed in one of this area I just zoomed in. Okay, can you see here? These are the inverted p waves, inverted p waves, where it's inverted as well as it's happening after the QRS complex. Okay, and sometimes this p wave can be buried in the t wave. Sometimes it may not be visible at all. So basically, if you get high heart rate, so let's say more than 150, and the rate is higher, it is going towards in the region of towards the number of arrhythmia. And if the is regular rhythm is regular, and if you cannot see any p wave, or you are seeing p wave after QRS, that is inverted like this, or sometimes you may not be able to see the p wave because it might have merged to the t wave. And if the QRS is narrow, then this is paroxysmal supraventricular tachycardia. Let's look at another picture. Okay, here what you, and the rhythm is regular. Can you see the distance is same across all the R waves? So it's the rhythm is regular. Now what about p wave? Can you see any p wave? That is, at least there is nothing before QRS complex, but you can see something after QRS complex, right? Something after QRS complex, but there is nothing before QRS complex. So in a way we can say that the p wave is absent, cut. If you look at this diagram, it's clear for you what is the rhythm is it seems to be regular. Rhythm is regular. And what about the rate? The rate is around, it's one box, so 300 divided by number of one box, so it's approximately 300. Now let us look at the p wave. Can you see any p wave? No p wave before QRS complex. Let's look at lead 2. There is no p wave before QRS complex, but you can see a p wave after QRS complex, a p wave after QRS complex. So we have got two features. One is regular rhythm and inverted p wave, that is after QRS complex, after QRS complex, regular rhythm. And if we take this QRS complex, it's narrow. So these are enough for us to diagnose that this is SVT. But well, it is definitely it's difficult to identify this inverted p wave in all the ECG. And to diagnose this condition better, just look at the wave, just look at the rate is higher, and you cannot see any p wave. I mean, superficially you cannot see any p wave. What is p wave for you? In general, it is the positive wave that happens before the QRS complex. In this case, when you superficially look, you are not able to see any positive wave before QRS complex, so assume that there is no p wave. Okay, but in reality, you know that there is a p wave, so assume there is no p wave. Okay, no p wave, I can't see any p wave, and the rhythm is regular, high heart rate, no p wave, and narrow QRS complex. Yes, then that is what? Then that is supraventricular tachycardia. All right, now we will go to another. Let me look at another ECG. Okay, here you can. It's very clear these inverted P waves. Okay, it's very clear for you. I have marked there. That is those P waves. You can see only one P wave here, right? It's not flutter definitely. So you can see one P wave here, one here. Those are inverted and happening after QRS complex, and it is narrow QRS. Rate is 300 here. Well, 300 can be two cases. Usually it will flutter and SVT can have a rate between 150 to 200, but as I told, it's not going to be flutter because you are getting only one P wave. All right, there is no sort of pattern. So how we will manage a uh, patient with SVT? Well, we can break the re-entry circuit by some maneuver that increases the vagus nerve activity over the SA node. One of them is Valsalva maneuver, and another is carotid sinus massage. All right, and the medical management is adenosine. So if the patient, let us say the patient is stable means the patient BP is fine, not collapsed, no chest pain, everything is fine with the patient, just some dizziness or not feeling well, then the first management is Valsalva maneuver. That is acute management, and if that doesn't work, then you go to medication called adenosine. And how you give adenosine? You give through IV. Preferable One of the preferable vein is anterior cubital vein, or if there is a central line, definitely that's better. Okay, if central line and IV both has given peripheral IV, then pick the central line. All right, and we give initial dose, that is 6 milligram. Wait for 2 minutes. If patient is not showing any improvement, give 12 milligram. Not showing any improvement, give again 12 milligram. If adenosine is not working, then you can go with beta blocker or calcium channel blockers. Beta blockers we use metoprolol, or in case of calcium channel blocker, we can use verapamil or diltiazem. All right, and one of the important contraindication of adenosine is what? It is asthma. If the patient is having asthma, you cannot give adenosine, neither beta blockers. Yes, maybe cardioselective you can give, but to be more safe, we cannot give adenosine as well as beta blockers. So what is the drug of choice at that time? It is calcium channel blockers, that is verapamil and diltiazem IV. That is the management. And if the patient is unstable, then only we know the management. It's a DC shock. Unstable in the sense, I mean syncope or low BP, then that is a management, giving shock for every all cases we have discussed. Patient is unconscious, arrhythmia, shock. What is the treatment? Permanent treatment, that is treatment of choice. It's the permanent treatment is to burn the circuit that has developed. Okay, to burn those re-entry circuit through catheter ablation. That's it. The main thing is about identification of SVT. So we have discussed, I have shown you the video on about this about SVT, as well as I have discussed the mechanism how SVT happens, and the identification inverted P wave after QRS complex. Sometimes P wave may not be visible because it might have blended with the T wave, and QRS complex and or narrow. QRS complex is a narrow regular rhythm. Yeah, that's it. That is how you identify. And I also told you that for if you want to identify SVT, just look at the ECG, and in your first sight you are not able to pick up any P waves. You are just seeing the QRS complex, but that is narrow and regular. Then that is going to be uh, more towards pSVT. And the management, vagal maneuver or adenosine or beta blockers or calcium channel blockers. Contraindication to adenosine is asthma. Patient is asthmatic, give calcium channel blocker, okay, instead of adenosine. Unstable shock, you should remember this adenosine medication, that is this dose, even 6 milligram, 12 milligram, 12 milligram. So in practice, if you want to identify the pSVT, the identify no P wave, and if the rhythm it is regular and QRS is narrow, then this is pSVT. Again, no P wave, I mean by looking at the ECG at the first sight, we are not able to see any P wave, but there is in fact P wave that is hidden in the QRS complex or in the T. All right, we have discussed that, but in your first look you are not able to see any P wave, because for you P wave means that is something, the wave is mostly positive that happened before QRS complex, which you are not able to see, and it's regular and QRS is narrow. And typically the heart rate would be in the range of 150 to 250. Then this is more towards pSVT, but at the same time no P wave, but the rate it is irregular, QRS is narrow. Then all of you know what this is, what case it is. It is AFib. So yeah, this really matter, regular or irregular. All right. Okay. Thank you so much. In next lecture, we will discuss about ventricular tachycardia.